From the News Channel 5 Network, this is OpenLine.
Good evening and welcome to Open Line tonight. I'm Carrie Sharp. We are in October, and you know October is known for many things. Pumpkin spice, just about everything, putting out the mums. It is also, of course, Breast Cancer Awareness Month. We've gotten pretty used to seeing those pink ribbons and pink just about everywhere you go. And tonight, we're talking about breast cancer. So if you have any questions that you would like answered tonight, now is the time to call. We're going to get those lined up. Numbers on the screen, 615-737-PLUS is the number to call if you have any questions about breast cancer, because I know my guests can answer them. I have Dr. Vandana Abramson with me tonight from Vanderbilt. Thank you for being with us tonight.
Thank you so much for having me. It's a pleasure to be here.
You are a medical oncologist. Let's just start with, what is that?
It's a physician who treats cancer. Medical oncologists focus more on chemotherapy and other aspects that are not surgical of breast cancer. So they're radiation oncologists who focus on radiation, surgical oncologists who do the surgery part, and medical oncologists who sort of take care of the rest.
Wow. Okay.
Yes.
So you have a very big job. Obviously, you know, it's Breast Cancer Awareness Month.
Yes.
I'm sure you talk about this a lot on a daily basis. Give me the overview of breast cancer. How prevalent is it? Because we talk about it so much. What's the reality?
Yes, so breast cancer is very common. Over the course of a lifetime, about 1 in 8 women in the United States is expected to develop breast cancer.
1 in 8?
Yes, so
wow.
It is very, very common. And actually the incidence is thankfully going down in the United States, but it still remains the most common cancer in the United States for women.
And the second deadliest, I read.
And the second deadliest behind lung cancer, exactly.
Wow. My goodness. So why is it declining? What are the thoughts there? That's good news.
That is great news. It's great news. So the incidence actually went up in the 1980s and 1990s, probably due to increased use of mammography, more screening. So people were more aware of it. Mammograms were more widely available. Physicians were more aware of breast cancer, so people were screened more, and there was an increase in breast cancer incidence because we were finding more. In addition, in the 80s and 90s, there were a lot of other factors, such as a more sedentary lifestyle, an increase in obesity, a little less exercise during that time, and probably some reproductive factors that led to an increase in breast cancer.
When you say reproductive factors, you're talking about the infertility treatments, that sort of thing?
That sort of thing, but also more women waiting to have children. So it turns out that having children over the age of 35 can increase the chances of breast cancer to some degree, and it's protective to have children before the age of 30. So there's that aspect of it. We also started seeing women menstruating a little bit earlier, probably due to some dietary factors. It's really not quite clear. So all of those things may have played a role in the increase risk or incidence of breast cancer during that time.
As I've read about breast cancer and learned about it today, and just over the years, there seem to be so many little factors that go into it that it's really hard to pinpoint, this is why you got breast cancer. You just can't do it, right?
You really, really just can't. But, you know, kind of going back to the incidence part and in terms of what could have caused it, what was very interesting is in 2002, we saw a sharp decline in breast cancer incidence. And that is when the results of the Women's Health Initiative were published.
I remember this,
Yes. So this was a huge study, a very, very large study. Over 100,000 women were being followed, postmenopausal women, for several years. But there was a hormone replacement therapy cohort. There was about 10,000 women who were getting hormone replacement therapy and another 10,000 who were not. The reason the study was being done was to look at whether hormone replacement therapy could help with certain factors, such as helping with heart disease, helping with bone health, and potentially helping with hot flashes and other issues.
Right.
But the study was stopped because it was noted that women in the hormone replacement therapy group had an increased incidence of breast cancer. So the results were published in July of 2002, and the following year we actually saw a 7% decrease.
That quick?
That quick. Wow. In breast cancer incidence in the United States and other Western developed countries. And actually every year after that to 2011, we started seeing about 0.5% decrease. Since 2011, the rates have been pretty much stable.
Okay, so maybe we took a big portion of the why and found it.
Yes. At least in a certain population, in that postmenopausal estrogen-fed group.
So about 1 in 8 women will get breast cancer. That's, I think, about 246,000.
That is correct,
a year.
yes.
About 40,000 will die. So obviously, it's a scary disease. And I think just as a woman, it's something we fear when we go to the doctor. And it seems like the recommendations for doing your self-exams, for getting mammograms, it's changed so much. And so often in the last 10 years, a lot of people are just left to be confused.
And I can understand why. The studies have been very conflicting, back and forth. Do we start screening at the age of 40? Do we start screening at the age of 50? Do we screen at all? Do we screen every year? Do we screen every other year? And when do we stop? At 74, 80, or never? And you know, it's hard to parse through the data. It depends on what it is that you're looking at. So we do know that breast cancer screening decreases mortality from breast cancer, and certainly in the group between the ages of 50 to 74. Outside of that, it's a little less clear. Between the ages of 40 to 50, the issues that arise are, well, first of all, there's just less breast cancer in that group. So when you screen more patients, you're going to end up getting more false positives, and you end up sending people for biopsies that are potentially unneeded.
Sure.
In terms of cost effectiveness, when you are screening thousands of women and finding one cancer, it may not be as cost effective as well. So there are a lot of issues there. We know for sure that 50 to 74 is good for screening. Between 40 to 50, I personally, at least in my practice, do recommend screening yearly.
Yearly, okay. And then between 50 and 74, again, keep it yearly.
Keeping it yearly.
Okay.
But I understand the controversy, and there are the United States Preventive Task Force actually recommends starting screening at the age of 50.
When you see your patients, do most of them, and they end up having breast cancer, do most of them come in because they have found a lump, or is it because of a mammogram?
Usually it's because of a mammogram. Although I work at Vanderbilt, it's a tertiary referral center, so I do get a lot of younger women who found it themselves coming in to my practice.
So those self-exams are still very important.
Absolutely, absolutely, especially in the younger group of women.
And with breast cancer, do you see other symptoms as well, or is it usually the lump that people find, or the mammogram?
Yes, it's usually the lump or the mammogram. Of course, there are some fast-developing breast cancers. People notice their breast can turn red and become warm, and but that's sort of a very aggressive subtype of breast cancer. In general, it's finding a lump.
What is treatment now for breast cancer?
So it really depends on the type of breast cancer.
How many types are there?
That's a great question. So, you know, it's when we sort of think back to how breast cancer came to be, or how it came to be where it is today, sort of think back to the 1950s and 60s.
Okay.
It was just breast cancer.
Yeah.
That's what if you had breast cancer, that's what you had. And then in about the late 1960s, it was discovered that some breast cancers actually have an estrogen receptor, meaning that they're being fed by the estrogen in the woman's body.
Okay.
And it wasn't until the late 1970s that it was really discovered that this is about 2/3 of breast cancers are fed by estrogen. And a drug called tamoxifen was approved for the treatment of estrogen receptor positive breast cancer. So tamoxifen blocks estrogen from getting to the cancer and feeding it. Since that time, we've had another big discovery, which is the discovery of HER2, or HER2. That's another protein on the cancer cell surface, and that's what makes that cancer grow. And it turns out that about 20–25% of breast cancers are what we call HER2 positive. And then we have the remaining, about 15 to 20% of breast cancers that at this point we call triple negative, because they're not positive for estrogen receptor, they're not positive for the progesterone receptor, and they're not positive for HER2. So they're negative for all three, meaning they're triple negative.
Is one of those more deadly than the other?
So, you know, HER2 positive breast cancer used to be considered the most deadly, but now we have treatments that target HER2, that block that receptor. So it's actually not as deadly. And now it's triple negative breast cancer.
Wow.
That's considered sort of the most aggressive, the most deadly form.
And is that where the research is really honing in on now?
We are focusing a lot on triple negative breast cancer. And a part of it is it's the most deadly because it's more aggressive looking under the microscope. It gets bigger faster, and we don't have a way to target it. We use chemotherapy, which really, when you think about it, is quite primitive.
Sure.
I mean, what chemotherapy does is it basically kills any cell that's growing quickly. So a cancer cell, even a slow-growing cancer cell, is growing more quickly than other cells in one's body. So chemotherapy just indiscriminately kills fast-growing cells, and that's why you get the side effects of chemotherapy.
That's why it's so toxic and so hard on people often. Yeah, you're just going in and trying to kill everything that's bad. And
right, exactly.
All right. At that, we're going to take a quick commercial break. If you have any calls for Dr. Abramson, she's going to be able to answer them for you tonight. We're going to be talking about breast cancer over the next hour. Stay with us.